Hello, you are listening to the RxConnect podcast. This podcast is brought to you by the American Oncology Network. I am your host, Melody Chang, Vice President of Pharmacy Operations at the American Oncology Network. Today, we are going to talk about biomarker testing for lung cancer. Lung cancer continues to be one of the leading causes of a cancer-related death worldwide, and non-small cell lung cancer makes up the majority of those cases. If we think back, treatment used to be fairly straightforward: surgery when possible, and then radiations or chemotherapy for more advanced disease. But over the past several years, we've seen a major shift. We're now in an era of precision medicine, where treatment is increasingly tailored to the biology of each patient's tumor. And that's exactly what we're going to focus on today: biomarker testing in non-small cell lung cancer, and how it guides us to the right treatment for the right patient at the right time. I'm joined today by Bradley Winegar, one of our regional clinical pharmacists at American Oncology Network. Brad, welcome. Can you start by introducing yourself to our listeners?
Thank you so much, Melody, for having me. Yes, I've worked in the oncology space now for 15 years, so I've certainly seen a great deal of changes in the non-small cell lung cancer world. I currently get to serve as the regional clinical pharmacist for clinics here at AON in Maryland, Virginia, Georgia, and North Carolina, where I live. So thanks again for having me. I look forward to this discussion.
Yeah. So let's start with the basics and build from here. When we say biomarker, what does that actually mean in the context of lung cancer?
Yes, that is a great place to start. A biomarker is basically something in the tumor, like a gene mutation or a protein, that gives us some insight into how that cancer behaves, and more importantly, how it may respond to treatment. In lung cancer, it's a very big deal to know because it really determines what therapy we choose. It's not just diagnostic anymore, it truly is guiding treatment for our patients.
Yeah, I like how you say that it's not just information only, it's actionable, right? How we guide the treatment actually. And that really reflects how much things have changed. So why has biomarker testing become so critical in today's treatment landscape? Can you just give us more details?
I can, yes. It's simply because the outcomes with targeted therapy for these biomarkers are so different. If a patient has a targetable mutation and we use the right therapy, we're talking about significantly higher response rates and often less side effects. So let me give two examples here. One of our biomarkers that we target is EGFR. We know from clinical trial experience with a certain EGFR mutations, these patients respond around 80% of the time, whereas only a third of these patients would respond, or we would expect to respond to chemotherapy alone.
Mhm.
And then the next example I'll use is truly one of the more amazing stories in all of oncology, and that's the target ALK in lung cancer. When we target ALK with our targeted medications called one of them is called lorlatinib. A clinical trial showed us that 60% of these patients were not only alive at 5 years, but had not even progressed at 5 years. In those with the ALK biomarker who we give chemotherapy, we would expect 50% of their cancers, of those patients, to progress in just 3 months. And so we're talking a half decade without progression versus just a few months. So these are dramatic differences, and I hope these examples show how important it is that we don't miss a actionable target.
Mhm. Yeah, that's very important information for the physician to know are they choose the right treatment for the patient, especially as your examples, it's such a dramatic change on the outcomes, right? So it's not about having more options, but it's about choosing the right option upfront. So for our providers listening, can you tell us what biomarkers in terms of non-small cell lung cancer should we be testing for today?
Yes, yes, I can. So, this is one thing where every organization agrees upon, from NCCN to ASCO to the College of American Pathologists to ESMO. They all support broad panel testing, which can assess all actionable driver mutations. And this list of driver mutations that we must now know has grown substantially during my career. At a minimum, we are looking at things like EGFR and ALK, which I've mentioned, and then others like ROS1, BRAF, KRAS G12C, MET exon 14, RET, NTRK, NRG1, and then, of course, PD-L1 as well. And this list doesn't even include what NCCN terms is emerging biomarkers like FGFR mutations or high level MET amplification. So there are a lot out there. And so the key message is we don't want to just test for one or two, but we want to do a comprehensive panel when at all possible. And that's really where next generation sequencing or NGS comes in.
Yeah, that's helpful. And I think where it gets even more important is how this actually plays out in the real practice. Can you walk us through what this looks like for a patient from diagnosis to treatment and where biomarker testing fits in?
Oh, yes. This is where things can either go really smoothly and we get really great outcomes or not. And so it starts with a biopsy, and that's usually done by pulmonology or interventional radiology. And ideally, at that point or immediately after diagnosis, biomarker testing should already be in motion. In a perfect world, pathology will automatically send off testing. That's what we call reflex testing. If that doesn't happen, then it falls on the oncologist at the first patient visit to order the testing. Testing is usually done through next generation sequencing on tissue, and sometimes we'll use a liquid biopsy if we need faster results or don't have enough tissue. Then we're typically waiting a week, sometimes 2 weeks for the results. And waiting is, of course, not easy and is an anxious time for patients, but this waiting period is incredibly important because, again, this is what's going to guide our entire treatment plan.
So you mentioned about pathologist will order the test, reflect test. But if a pathologist did not order the test, would the medical oncologist, or even sometimes the patient's getting the surgery done in a hospital, would those biomarker testing being ordered by other providers as well, other than pathologists?
This is a great point. Sometimes it's not clearly owned who orders this. Sometimes it's pathology, as I mentioned, sometimes oncology, and sometimes there's an assumption that someone else has already done it. And that's why we need clear workflow or a standard operating procedure is so important so that every patient gets tested no matter where they are in the system. And I'm actually working with a colleague and one of our physician leaders on an SOP right now that we hope to have out to the network in the next month or so. And the hope for this SOP is that it will help clarify what our organizational expectations are for biomarker testing in this setting.
Right. Good to know that you're working with the SOP and that will set the standards for the practice, being able to follow, right? So, can you tell us what are the biggest barriers you see today for those biomarker testing being ordered?
Oh, yes. This is something that I've been reading a lot over this past month, and there's a few big challenges that come up over and over again in the literature. And first is tissue. Sometimes we just don't have enough. Over 80% of non-small cell lung cancer specimens are obtained from small biopsy techniques, and that percentage continues to rise. And fine
Mhm.
needle aspiration biopsy is certainly patient friendly. I know that's what I would want, but it's not
Mhm.
always biomarker testing friendly at times. Second is turnaround time. Waiting for these results can be tough, especially if the patient is symptomatic. And then there's the complexity, both in understanding what to order and how to interpret the results. Also, even things like EMR integration can play a role. I remember in 2022, just a few years ago, we got our first approval for the HER2 mutant lung cancer. And a physician asked me to help look back at some of his patients to see if they had had HER2 mutation testing done and if it was positive. And so I thought it would be an easy search, and I quickly found out it wasn't as simple as typing HER2 and searching. I had to go through pages of reports, and it wasn't easy to find. Uh,
Mhm, mhm,
lastly, unfortunately, there's a payer issues can sometimes be a challenge, but those are the major challenges that I have seen in the literature.
mhm. Yeah, you highlighted those key challenges as really, really real barriers we see today. That including, you mentioned, yes, tissue. Tissue is the issue, right? Resolve as soon as possible. Sometimes it's easy to know when can I start the treatment, right? And then obviously fishing the results from the EMR system and could be a challenge as
Very
well
true.
as the payer coverage.
Right.
So, and I think that leads into a very real clinical dilemma. And how do we balance the waiting for a result versus starting the treatment?
Yes, that is a tough judgment call that our amazing physicians really have to make on a daily basis. And I will say that if the patient is stable, the best approach, no doubt, is to wait. Because once you start treatment, especially medications like immunotherapy, you may limit future options. If they're not stable, you may need to start treatment, of course, but you still need to be very selective and thoughtful about what you choose. And I'll give an example here, and that example would be immunotherapy. Immunotherapy has been one of the biggest game changers for us in the oncology world and has changed so many lives. But in patients with certain biomarkers, it appears to be not only less efficacious, but more toxic. And so, another reason why if at all possible, we need to wait until we have our entire biomarker testing back before we initiate therapy.
Yeah, that's very, 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 very important. And sometimes we need to wait, and waiting is tough, it's hard, but for the better outcome might be necessary. Now let's talk about the pharmacy. As a pharmacist, where do you see a pharmacist fitting into this picture?
I think this may be my favorite question thus far, and in my view, it's a huge opportunity for us in the pharmacy world. We can catch missing tests, we can help interpret the results, we can support our providers in decision making, and we can make sure that patients' treatment aligns with their biomarker testing. There are some very neat pharmacy-driven biomarker testing projects in the literature. And it's my goal after our SOP and our educational events occur that we also contribute to that literature in the form of a publication. So this is super exciting, and I hope you can hear in my voice that I think this is going to be a great example of where pharmacists can be directly involved in impacting patient outcomes.
I completely agreed. And then this is an area we really focus on at AON today, as well as this is our 2026 pharmacy important initiative. How do we encourage the biomarker testing, as well as how can we bring the awareness and then create something and can be useful for the system? So to wrap up, Brad, can you give us the final one message you want our listeners to take away?
One key takeaway. Let's see what I want to go with here. I think that I would say that biomarker testing isn't just part of the care. It's the foundation of care in non-small cell lung cancer. Getting that right up front can make all the difference. And to wrap up, I just want the audience to know that there have been a rapid development in identifying a large number of targetable molecular drivers in non-small cell lung cancers. And for patients with tumors containing these drivers, targeted therapies are often more efficacious and less toxic than standard chemotherapy. In fact, amazing medications like immunotherapy may be less efficacious and more toxic if utilized in patients with certain driver mutations. So, to conclude, I just want the audience to know that it is imperative that patients have access to appropriate biomarker testing upon diagnosis to ensure proper therapy, as these targets drive treatment decisions in both early and late stages of non-small cell lung cancer. Thank you.
Thank you. I love that. Yeah, getting it right up front really sets the course for everything that follows. Brett, thank you so much for joining us today. This was a really practical and insightful discussion. And to our listeners, thank you for tuning in. We hope this conversation helps you continue to bring the best, most personalized care to your patients. We look forward to connecting with you again in our next episode. This podcast is brought to you by the American Oncology Network. Stay tuned and be safe. Thank you.
The RxConnect podcast is produced by the pharmacy operations team here at American Oncology Network and music composed by the Synth Dude. Make sure to check out all our episodes of the podcast by liking and subscribing to our YouTube channel.